Assalamu alaikum. Just let me know, please, if the sound is okay.
Walaikum assalam. Yeah, we can hear you, doctor.
All right, so today I'm sorry, just the video. I don't want to risk the internet. I just wanted to check in, make sure that everybody is okay with the exam and the questions. I hope that they were, fair, reasonable, not too difficult. I don't know yet about if the grades were published or not, but I think it was a reasonable exam. So we're gonna now continue with sort of a different set of topics. The first were all about development and developmental trajectories. Now, the next set of topics are kind of individual, each targeting a different topic, so a bit more diverse, not so continuous. Now, your final exam will focus primarily on the new set of topics, but will still include some, questions from the previous set of lectures. For today's lecture, I do need you to refer to the PDF because there are tables that you need to go back to for like it's more elaborate. So I'm gonna like highlight some things today, but I do want you to go back for sure to the tables and I'll point them out as we go along. Today I'm going to cover two lectures, one from last week's and one from today. Hopefully we'll have time. The reason being is that they're like connected. So part one and part two of theories of personality development. This is kind of core for psychiatry, really. Understanding we understood the sort of the normal development in terms of skills, language, cognition. So these are all like, skills and abilities that we, acquire. Genetics plays a large part into it. Then you have the formative years where your environment affects and shapes who you are as a person, plus your innate characteristics. If you remember the temperamental characteristics that were discussed by Chess and Thomas, so that's kind of like, your temperament, your cognitive abilities, your social skills, the environment that you live in. All of these go into then, shaping who you are as a person. Okay. So there are so many theories available, okay, that help us in understanding how humans develop in various aspects. I mean, that when you sort of go on to do psychiatry, if that's an interest, you learn about like so many people, scientists. But for sake of this course, I've just chosen a few that kind of give us an overview. So is everything as like, can you guys hear me? It's okay?
Yeah, we can hear you.
All right. So how do we become the people that we are today? Okay. So these are the main contributors that I've chosen to like highlight, but I'm not going to cover them all. Some we've already talked about. We've talked about Piaget, we've talked about Winnicott, and some we're gonna cover over the course of these two lectures. And so these contributors have then divided themselves into schools. So there's a school of ego psychology, there's a school of object relations, and there's a school of self psychology. Okay. So Freud is the father of ego psychology, and I'm sure many of you have heard of Freud in terms of just maybe in movies, in history, a well-known name for his contribution to, and what he's most famous for is something called psychoanalysis. And that's what psychiatrists then became famous for. So the famous, like depiction of a couch, somebody, lying down on it with a therapist in the background, where the patient or client is, talking and very minimal interaction from the therapist. And that's the basis of psychoanalysis. So, a little bit about Freud. So, Freud was born and raised, born in the Czech Republic, and then moved with his family to Vienna, where he lived and he finished his medical school. And after that, he moved on to Paris, where he worked with neurologists. And so one of the first cases that he worked with was a case of Anna O. That wasn't her name. That's just the name that was uh, given to her, but I mean, to protect her name. So what happened was he was working with uh, uh, under the supervision of a neurologist who, working with this woman, saw that she had very unusual symptoms, things like paralysis in her limbs. She wasn't really able to speak. Well, she had hallucinations, she had memory disturbances. And at the time, they diagnosed her with what was known then as hysteria. So, and that's a very old term to describe people who have psychological disorders with physical symptoms. Then, when they were taking care of this woman, they noticed that whenever she talked about any of her painful experiences, her symptoms improved. And so then came the idea of, talking cure, that when people talked about their emotional stressors or distressing moments, that could relieve tension, could relieve stress, would relieve symptoms. And so that became kind of one of the earliest examples of psychotherapy. Now, it became really the foundation of psychoanalysis. So the case of Anna O, and she was a woman who was taking care of her father who had a stroke. Okay. So the stress of dealing with him in turn caused her to have physical symptoms, and hence she had the like limb paralysis, speech difficulties, which was very much mimicking her father's stroke symptoms. So in psychoanalysis, there's a suggestion that a person's unconscious emotional conflicts are going to cause physical symptoms. And it introduced an idea of something called catharsis, which is a relief or a release through expressing emotions, so that when people express and then they cry, that kind of is a release. It's as if you have a bottle that's about to explode, and then you just, make a tiny opening, and so it just releases everything. And it really helped Freud to be inspired, and then, work on his later theories. So it kind of introduced things like, what is resistance, what is repression, and what is free association. So free association is pretty much when, somebody is in the time of psychoanalysis, sitting on a chair or a couch with minimal interaction from the therapist. So usually you'd find these like memes or whatnot of somebody just saying mm-hmm, like as if like just as the client is talking, and the therapist just hums or or acknowledges with a hum, not really much words. And so free association being that the person is just, saying whatever comes to their mind. And then the therapist tries to make some connection between these, free floating ideas. One of the things that was very specific to Freud was that his work and theories, they changed over time depending on the type of clients that he was working with and if he encountered any sort of obstacles or he had observations that would then lead him to developing a theory. So, of his first was the interpretation of dreams. And actually, there's a book called The Interpretation of Dreams for Freud, where he says that the dream is a disguised fulfillment of an unconscious childhood wish that is not readily accessible to the conscious awareness in waking life. So that when we dream, it's kind of like your unconscious mind dwelling in like or free floating with very little restrictions, and he believed that it was all related to unconscious childhood wishes that were suppressed or repressed. And it became the foundation of ego psychology. And when he talks about dreams, he says that there are two layers of any dream content. So there's the manifest layer or the manifest part of the dream, and then there's the latent part that he called the dream work. So the manifest part would be what you remember. So you wake up in the morning and you remember, and so you go to your psychoanalyst and you say, well, yeah, I had a dream, and you start talking about the dream. You're in a car, you're driving in an open area, or there are fields. You see random people, so you're just describing what you remember from your dream, and that he says was just the manifest part of the dream, which was two psychoanalysts, kind of like the tip of an iceberg. What was more important was the latent part or the dream work. So what are when you're expressing or describing your dream, what does it really mean? What are you referring to in that dream? And he tries to make sense of or connect things to make sense of whatever it is that you're dreaming of. So he says that the dream work is, certain concepts. So condensation is when in a dream you see a face, for example, but it doesn't really remind you of anyone that you know entirely. But you think that the eyes look like, your high school teacher's eyes. The nose reminds you of a driver that you used to have, or so that kind of bits and pieces of the face. And so that is what he called condensation, is when different parts of your life come in together into one picture. Okay, so that picture may not be entirely clear to you. However, when you start to like take it apart, then each part relates to something that's relatable to you. Then he talks about displacement, and he was very notorious or well known for a phrase that's murderous rage. Okay, so murderous rage is example in a dream. You dream that you're like killing somebody that's completely random. Okay, and so he would interpret that you have this rage towards somebody who's really close to you, and usually for him it'd be like a parent, one of your parents. You've got this extreme anger to the point where it's like murderous, but because that's very difficult to imagine, it's displaced onto some random person in your dream. So if the client was talking about like in a dream they're like hurting somebody or like murdering somebody, he would interpret it or take it back to that this person has unconscious anger towards somebody who's very close. Symbolic representation is things that you see in your dream that he would then interpret them to symbolize something. So it could symbolize, like, it could be, a very non-symbolic, you're in fields where there's flowers or there's birds. And so he would, uh, you know, say that, for example, that the bird is a symbol of life, or the flowers are a symbol of youth, something like that. So, whatever it is that you describe, he will, take it to another area and sort of can make a connection, and then it's a symbol of something. He talks about secondary revision of dreams because dreams have like two different processes. So he talks about the primary process thinking, which is, and we all have that, like very illogical or bizarre, things in our dreams that don't make sense to us. So he says that that's primary process. So it's illogical, like bizarre, like very absurd images that don't really seem coherent. And then we have secondary process thinking or secondary revision, where the dreams become a lot more like rational. And so it's parts of our dream that are just completely disorganized, and then our unconscious mind tries to make sense of, and so puts things into like more of a perspective. Afterwards, he went on to another set of thoughts that he called the topographic model of the mind. And so the mind was divided into three layers, and it's not an anatomical division. So it was based on what he thought would manage or store unconscious wishes or desires. So he divided the mind into three levels or layers. So the conscious part of your mind is the one where perceptions would come in from the outside world or from within the body, and they're brought into awareness. So it's your senses, what you see, what you feel. So it's something that's accessible to you, and you can communicate that by language or by behavior. Okay. Now, the preconscious part of the mind is the one that it's a layer between the conscious and the unconscious mind. And so it's mental events, processes that can be brought into conscious awareness by focusing of attention. So things that have happened to you in the past that are stored somewhere in the back of your head, and that you can bring to your awareness by just, trying to remember. So you're sitting with a group of friends, you all went to school together, and you're trying to remember that, kindergarten teacher. So she's somewhere there in your mind, but you can't quite remember. And then, a bunch of you sit there and you collectively remember. And so then that image goes from your preconscious mind to your conscious mind. So it's that interface between conscious and unconscious regions of the mind. And it kind of maintains a barrier to censor unacceptable wishes and drives. So it kind of buffers out. And the reason he believed this was that whenever unconscious wishes or impulses would come to the forefront, they cause symptoms. So therefore, the mind had so many like buffers and stoppers to make sure that all these unconscious wishes to that were kept in place to avoid symptoms. Now, the unconscious part of your mind is where mental contents are kept from conscious awareness through repression. And we'll talk about that in a bit. So, defense mechanisms, that's how our body keeps unwanted thoughts, feelings away from our conscious awareness. it's by these defense mechanisms that, kind of suppress, repress. And so the content is very much limited to wishes that seek fulfillment. It's categorized by primary process thinking, and it's governed by pleasure principle. So he would talk about aggressive type thoughts, wishes, sexual type thoughts, wishes. And those are like the two main categories that would be, needed to be kept under control. And the reason it's a dynamic system is that these can come to the forefront. And that was the whole point of when he learned hypnosis. So hypnosis is the means by which thoughts, wishes from your unconscious mind can surface to your conscious mind. And there are people who do study hypnosis and that use hypnotherapy. In my residency, one of my supervisors was a hypnotherapist, and he worked extensively with people with multiple personality disorders. So people who have multiple personalities, and so they tend to dissociate. And he worked with them through hypnotherapy to bring out, all sorts of unconscious type thoughts to the forefront in a therapeutic, obviously, environment. And the objective is treatment. Nowadays, people can use hypnotherapy to help with anxiety, phobias, stopping smoking. Even some try with, weight loss. So there are like more modern uses for hypnotherapy. The limitations of this topographic model of the mind was defense mechanisms. So these kind of get in the way of info or feelings going from the unconscious part of your mind to the conscious part of your mind, as well as he calls it the unconscious need for punishment, which is how some people, their unconscious mind wants to keep them unwell. And so it became really the basis to understand conversion disorders, pain disorders, somatoform disorders. So there's a bunch of psychiatric diagnoses that really go with this theory where, there's not a medical reason for why a particular patient can't see or they can't walk, or why they have, seizures when they're not epileptic. So part of working with conversion disorders is trying to understand further what is the gain from the sick role. What does this patient gain from being sick or being ill? What is the secondary gain? And once you can identify that, it then helps in, relieving their symptoms. So the lessons learned that he learned from this model was that there is process thinking, which is the bizarre logical thinking, the importance of wish fulfillment. So whether it's, the sick role or secondary gain, and that people have a tendency to regress, and that this type of tendency to regress can be protective. So regression as a defense mechanism, we'll talk about in a bit, can be normal and it can be abnormal depending on, what is its function. He then moved on to the instinct or drive theory, and this is one of his most famous. And so we know instinct basically is a very species-specific behavior. It's genetically derived and it's independent of learning. So our basic instincts are, set there for survival. So the need to eat, the need to sleep, the need to reproduce. So these are instinctual behaviors that we don't, I mean, nobody's taught us. It's just part of our instinct. And so he says that the characteristic of any instinct is divided into four. There's a source, which is, from where is it coming? The impetus is the energy. The aim is what it is that one needs to do, and the object is usually the person. So example would be, hunger. So you are hungry, the source being, your stomach or hunger, pain. The impetus, so the level of hunger or, the interest to get up and aim, make a sandwich to feed yourself as the object. So these all go into then how he talks about the drive theory. The stages of psychosexual development that he talks about, and this is where I also need you to go to the PDF because there are tables there that you need to go through. So he talks about 6 stages, and they're chronological in order. So the oral stage is from birth to around a year or a year and a half. The anal stage is from a year and a half to around 3 years of age. Then he put the urethral stage is up until, in that same range of 3 years of age. Then we have the phallic stage from 3 to 5. Latency is from 5, 6 to around 11, 13. And then the genital stage is from 11, 13 onwards. And in every stage, he defines it, he describes it, he talks about its objectives, its pathological traits. So what would the outcome be if things didn't progress as expected? And then, the character traits are those resulting from a successful resolution. Or so if you go through the oral stage normally without any interruption, then what would be your character traits? So from birth to around 12 or 18 months, which is like, again, the earliest stages of development. So here, the definition being it's a focus on the infant's needs. So he describes it as oral because it's really around feeding. So here it's about feeding. So it's about the mouth, the lips, and everything related to the oral zone. And in this stage, the infant is seeking feeding, but also feeding is symbolic of trust. So whenever they cry and they are fed, versus they cry and they're sometimes fed, sometimes not fed, versus they cry and they're fed way after their need to be fed. Okay. So you can imagine if you have an infant raised in these different scenarios. So an infant that cries and is fed on demand. So therefore, they develop a sense of basic trust with the outside world. Again, they don't know that, a 2-month-old doesn't know that there's a mom, there's a dad, there's life. All they know is that, I cry when I'm hungry, I need to be fed, or I'm wet, I need to be changed, or I'm in pain, I need to be soothed. All right. So these are kind of the basic needs. So every time they cry, they're fed, or they're changed. So then they learn to anticipate that there's going to be a response that's guaranteed. So that becomes like a trusting relationship versus, I'm sometimes fed, I'm not, sometimes not fed. So, what is this outside world that is not consistent? And then you have a scenario where, you know what, I'm not fed. I cry and I'm not fed. And so there's going to be a lack of trust, plus a sense of neglect. Okay. So, I mean, the description could be a little bit more sophisticated. I mean, when you think about a 2-month-old, obviously they don't have the cognitive abilities to think about, oh, like I'm in a world and I don't trust anyone, or yes, I do trust. No, so it's not that. It's a feeling, it's a sense, and it sort of becomes more imprinted over time that, I'm hungry, I'm fed, I'm wet, I'm changed, I'm safe, you know, versus, it's not, I don't know what to expect, when to expect. So this is a very random world. So I'm very confused and conflicted. And this also goes into, when we talked about attachment, and it starts off with very basic things like feeding, and then goes on to having a secure attachment because it's predictable versus having something that's insecure or ambivalent because it's just, conflicted. All right. So that's the description. It's the triad. He calls it the oral triad, which is a wish to eat, to sleep, to relax. And so the objectives of this stage is to establish a trusting relationship with the outside world. Okay, whatever that world is, a caregiver, whatever it is to develop that trusting uh, relationship. Now, things can go wrong, so you can develop pathological traits. And again, they could be on extreme ends. So either that you have excessive oral gratification, okay? So that, you don't even need to cry. You're fed immediately, right? So versus, okay, I cried, so the baby cried, expresses a need, and then the need is met. And then you have where, they didn't need to express, the need was met before even it was expressed. Okay. So if you have that first scenario, you have this excessive oral gratification. Okay. On the other end is an oral deprivation. So there's a need that's not met. Okay. So a need that's not met. On one end is a need that's met before there's even a demand. So that's excessive both ways. So if you have the excessive gratification, you develop traits of like being excessively demanding, entitlement, growing up. I mean, if that's been your oral stage moving forward, your relationship with the outside world is, I want it before even need it. I want it before I even ask for it. Okay, so you get these people that are so entitled. And so when we see these people in therapy, Freud would, you know, speculate that they had issues in the oral stage, that when they're like 12 months old or younger, there was an issue with feeding. Okay. Now, that is excessive because when you sit with a 25-year-old or person, and they're talking about like their need, how they feel entitled and how the world is not meeting their needs as they expect. It's really hard for someone to sit there and recall what it was like when they're 1 year old. Number one, they're not going to remember because we know that memory hits when, closer to after age 5 when you have more language. But for Freud, it's a collective experience. So if someone presents with that type of problem, the speculation is that most likely, this person, it started, from infancy. On the other end is someone who was not ever fed and was kind of neglected. They go on to be extremely clingy, clingy, dependent, as a pathological trait. Whereas if it was a normally developing person, like infant, where they're fed on demand, he calls it a successful resolution of the oral phase. And then they go on to be able to give and receive from others, not excessively dependent, not excessively clingy or entitled. Okay. So that would be the oral stage. Moving on to the anal stage, which is a very interesting and critical stage as described by Freud. So here we're looking at age up to 3. Okay. So it's toilet training. Okay. So it's a time where you have sphincters maturing. So your anal sphincter in terms of control of the toddler, controlling what they let out versus not. So they're starting to have more maturation and neuromuscular control over their sphincters. And so here it's a period that extends from the age of 1 to 3. And so it's kind of an interesting phase where between being autonomous, like, going to the bathroom when you want to versus being punished if you don't. Um, so it's kind of a struggle that toddlers have with a caregiver to be autonomous, and to kind of be separate versus to be controlled. Where infants or like toddlers, according to Freud, feel that the only way to be autonomous is to control that sphincter. And so there's this struggle that happens with toilet training is that, if toddlers feel overly controlled or punished, or the parenting is harsh, there's going to be issues with the toilet training, and where we start to see kids having encopresis, which is, letting out stool when they shouldn't, in places where they shouldn't as well. So it becomes a struggle. And the objective here is to really foster a sense of separation from dependence and separation from being controlled by the parent. You need to go to the bathroom now. You need to go, we need to change now. So that type of parental control. And so the objective in the anal stage is to become independent of that. Now, the pathological traits that come out of that is, again, the extremes of when you have extremely harsh, controlling parents. Okay. You have toddlers that go on to be extremely stubborn, not flexible. And in lay terms, I don't know if you've ever heard the term, like when someone tells someone else, I don't know why you're so anal. Okay, so that term comes from that description. So somebody who's quote unquote so anal is somebody who's really inflexible, very obsessive, very orderly, like, they can't deal with things not being organized or in order. So that's one end, because parenting was super harsh around the toilet training process. The other end is, when you have parents that are just extremely lax, don't really tend to this training. And so you have a pathological trait of somebody who's very like messy, not tidy. That would be the extreme. And so the character traits or the successful resolution here is really the basis for developing personal autonomy, okay? To be able to be independent, to have initiative. Like, again, when you think about a toddler, and this type of description, it seems so intense, like, autonomy, initiative, at the end of the day, it's just toilet training. But that's the stem of development of your character traits. So now you have somebody who, as an infant, they're fed on demand, so they develop a safe, trusting relationship with the outside world, and then they go on to the next stage where parenting was not so harsh and it was not so lax, and they were able to develop a sense of autonomy and independence. So that would be, normal, healthy development of personality character traits. Now, interestingly, here, when people move from one stage to the other, you don't need to complete the work, okay? Because you're growing, people are growing. So you could move on from one stage to the next, carrying with you like baggage or luggage, unfinished business, So you can go on to the anal stage and then have parenting that's, you know, uh, allows you for independence, although maybe your parents earlier on in life, were not like you were not fed on demand, and so you were not really trusting. So you can go on to a stage and develop it normally, even though the stage before that was not like too healthy. All right. And so when people arrive to therapy, you can imagine how you've got like luggage, baggage issues from different stages, and then they present to you as a human being with a bunch of, issues. And so Freud would sit there and untangle. and go back to, at what stage was there a problem, and, how can we resolve it? The urethral stage is, one of these more neutral stages. He was not he was not very explicit when he sort of talked about it. It's between the anal and phallic stages of development. It has characteristics from the anal stage and from the phallic stage. And here, the description is related to performance, control of more the urethral function, with the objective, again, of having control over one's life. Pathological traits, he talks about predominantly competitiveness, how that can come out of not well managed. And I mean, competitiveness could be a healthy trait, but it also could be pathological if your life becomes about competition. And then the character traits coming out of that would be a sense of pride and self-competence. This is another stage where he spent quite a bit of time trying to understand, that stage in terms of how it could develop normally, and more so, what happens if it doesn't. So this is from age 3 to 5. And remember when we talked about children developing during that time period, and it's really discovering your body, discovering that your gender, knowing what you are, who you are, knowing that you're different from others. So this is that, you know part of your development. And he talks about the Oedipus complex, all right, and that's the triangular triangular relationships. And so he talks about mother, father, child. And this child could be boy, and so outcome is different, or child is girl, outcome is different. So in this triangle, if the child is a boy, okay, he talks about how the boy competes with the father for mother's love. Again, I'm not going to say you're going to take that with a grain of salt. If somebody is a Freudian therapist, that they're a firm believer of this. But it's also, hard to imagine that you have a 3-year-old who's got that complexity of thought and feeling to, sit there and be threatened by their dad for their mother's love, and to actually verbalize that. But that's what he thought was the reason for why people then developed, what we're going to talk about in a bit. Okay. So he talks about it explicitly that boy competes with father for mother, but he always brings down things down to, anatomical description. So he calls it, the penis envy, where it becomes that focus. He actually says for both sexes, boy and girl, so that boys will compete or have that penis envy, and that becomes the area of competition for mother's love. And so how does that resolve? Is that, obviously he says that the child realizes that fear of what he calls fear of castration, that, if I'm going to continue competing with my dad, then that is could be a punishment. And so it resolves by then the boy finding, love that is like mother, okay? Because I cannot have mother, I will find somebody else like mother. And we see that like in sort of in some cultures where, a young man will say, I want to marry somebody just like my mom, who cooks like my mom, who does everything like my mom. And so that's such a Freudian, like, exercise. And Freud would definitely comment on, well, if somebody says, I want to marry somebody like my mom, obviously it's not a sexual thing, but it goes back to conflict, in that age, and it's that Oedipus complex, okay? So the objectives here is to kind of have that foundation of gender identity. Okay, with pathological traits being, fear of castration, having issues related to, gender understanding, and the character traits is that the phallic stage will provide an emerging sense of sexual identity, curiosity without embarrassment, initiative without guilt. And again, you're talking about toddlers, 3 to 5, and we know that, there isn't that sexual maturity yet. But he talks about, how that lays sort of the foundations for, issues later on in life. So the resolution for boys for the Oedipus complex is that, castration anxiety. And so they identify with the aggressor. So the aggressor being the father. So if I continue to compete with my father, I will be castrated. And so the aggressor is my father. So instead of competing with, I'm going to identify with, and therefore I will seek somebody like my mother. And hence, I want to marry somebody like my mom who cooks like my mom, etc. Now, for girls, he calls it the Electra complex or penis envy, where the girl, he says, feels castrated. Again, this is very hypothetical. And so that in that competition, the girl realizes, so I'm not able to compete because I don't have, that. And so he thought, and when you read about this, there was a bit of like struggle that he had to understand how girls have a resolution. So he says that there's 3 outcomes for that. He calls it quote unquote genital inferiority, where either girls become hyper masculine to compensate for the lack of, or they are asexual, or that they develop normal sexuality. So the fear of losing mother's love is what leads to the resolution, according to Freud. Okay. Now, the latency phase, it's from 11 to 3, and from its name, latency, so not so much governed by like hormones or anything sexual. So this is, he calls it a stage of relative inactivity of sexual drive. And so the description, it's the here, basically, the main function of this is to, strive, to learn, to work in a group, developing important life skills with the objective of really consolidating, sex role identity, sex roles, again, boys, girls. Pathological traits here are really more in the area of skill development and learning. Okay, it's a very latent stage. And characteristic traits would be more like developing good adaptive function. How do you fit in a group? How do you learn? So that's kind of the latency stage. And then the last being the genital stage. So it's pretty much early adolescence into and onwards. So the genital or adolescent phase, he divided it into like, either early adolescence or pre-adolescence or middle adolescence. So it's around that time. And it's here, the hormonal system and how that, starts to add to the picture. And so intensification of drives, and pretty much more about like mature sexual and, sexual identity. The objectives is really for adolescents is to become separate and autonomous from parents, and to be comfortable with your sexual identity. Pathologically, is sort of lack of proper, let's say, understanding of oneself, your psychosexual development, failure to resolve, whatever adolescent issues. And then to have the character traits of being, somebody who's fully mature, capacity for, understanding sexuality and gender identity and gender role. So a lot of, again, people will talk about, when is it that people start to have confusion about identity and gender? So, it can start off from early age, from the age of 3 to 5, and then continue into adolescence, where the hormonal component adds further to if someone has some confusion. Afterwards, finishing off with the psychosexual stages of development, then he goes on to more looking at, another sort of set of ideas. And he talks about ego psychology, the id, the ego, and the superego. The functions of the ego. So the ego is the part of us that is the interactive part of us, let's say. Okay. Your id is the part of us that will want to do things that are driven by wishes and drives. And your superego is the part of you that is your moral or ethical, let's say, uh, part of yourself that will, govern your overall behavior. So there will always be a struggle between the id and the superego, where the id wants, freedom, whereas the superego will want to kind of restrict. Okay. So functions of the ego would be the control and regulation of drive. So it kind of tries to do a bit of a buffer. It's that for judgment. It's that part of us that helps us judge, relate to reality, sort of object relations. How do we relate to, people around us, relationships, that sort of thing. The autonomous ego functions are related to learning, development of skills. So things like he talks about how sometimes people go on to, let's say, for example, I have a patient who's diabetic. I saw yesterday, and she's 15 years old. She's not at peace at all with her diabetes. She hasn't come to terms with it by any means. She's extremely angry, you know, at the world for why she has diabetes. But interestingly, she's very defensive and angry, but she wants to then go on to become a doctor. All right. So this anger, she will then, wants to go on to be a doctor to work with, diabetic people in order to help them. And then with things like the synthetic functions of the ego, this would involve skills such as organization, coordination, so kind of more frontal lobe type things, and how do you, manage data. He then goes on to defense mechanisms. And so defense mechanisms is really, let's say, the bread and butter of psychotherapy. So it's something that we have to understand as therapists, but also it's important to know that every human has defense mechanisms, all right? Depending on, if they're healthy defense mechanisms or not, we get symptoms. Okay. So they're grouped according to the degree of maturity that's associated with them. So they're divided into 4 groups. There's the narcissistic group of defense mechanisms, immature defense mechanisms, neurotic defense mechanisms, and mature defense mechanisms. So obviously, more pathology is seen with the first one, two, and a bit of three. Whereas, if you have mature defense mechanisms, these are really protective. Again, for defense mechanisms, I do need you to go to the tables in the PDF. You will find that there are a lot more defense mechanisms listed, but for the purpose of your exam, we'll just focus on the ones that are mentioned in the slides. Okay. Now, because we all have defense mechanisms, it's important to understand them well because, when we work with clients, when we identify these defense mechanisms, that's how we have our breakthrough. Okay. But we don't tell patients or clients that, oh, you're so in denial or you're passive aggressive, or, I mean, we don't name these defense mechanisms because these are all very unconscious mechanisms. Okay. Defense mechanisms are things people are not aware of. They're not aware that that's what it is that they're doing. So when they come into therapy for whatever reason, relationships, self-hate, whatever the symptom may be that brings them to therapy. And then they start to, in therapy sessions, talk about life. And remember when we talked about Winnicott, where the therapist becomes that holding environment for the client to show their true and false self. So hopefully their true self. And so when they start to talk about their life, and then you start to identify patterns and trends of behavior, and then you start to, understand this person further from a defense mechanism perspective, that, this person is dealing in their day-to-day life with this set of defense mechanisms that makes them unable to cope. So these are not helpful. They are very pathological defense mechanisms, and then we start to like focus on how we can not undo them, but let's say understand them, have more insight about them. Again, depending on, the pathology at hand. So for narcissistic defenses, the ones that I will want you to know about are denial, distortion, and projection. So denial is something we use in lay term. You tell somebody, "Oh, you're so in denial." So it means that there is a problem that for whatever reason they're not willing or wishing to acknowledge it. Okay, so it's kind of avoiding the awareness of an aspect of one's life or one's emotion, and it's protective. So when you're in denial, it protects you from these, unpleasant realities. Okay, but then you become like an ostrich. Your head is in the sand because you're in denial, but then you're not dealing with issues in your life. So in that sense, if it becomes something that is a predominant way of function, predominantly denial is part of your life, then it's not healthy. Okay. Whereas when it happens and it doesn't affect your life because we all will have bits and pieces, then there isn't dysfunction. Okay. So denial really, it kind of protects people from their external reality. We go on to distortion, which is the reshaping of external reality to suit inner needs. Okay. And we tend to see that with psychosis, so psychosis, hallucinations, delusions are all a distortion of the outside reality. So this is definitely not a healthy mechanism. Is it protective? It could be at some level, but it protects this person from some very harsh outside reality, but it's obviously not healthy. And so especially if it becomes a complex sort of delusional system. Okay, so when people tend to distort, okay, or again, it's not a conscious thing that they're doing, but things are distorted. It affects behavior because I'm going to deal with the outside world based on my distorted perception of this outside. Okay. So I'm going to be suspicious, I'm going to be paranoid. Now, whether that is part of a personality disorder, like I don't know if you did personality disorders or not yet, but you can have, like cluster A personality disorders where people are more like paranoid, schizoid. So there's a lot of distortion as a defense mechanism that's used because everything's distorted, but they're not psychotic, they're not schizophrenic. Okay. Then you have projection, okay, which is when you perceive the outside world in a way and you react to it because your perception is unacceptable. You have unacceptable inner impulses. So it's easier for me to think that the outside world doesn't love me versus me, dealing with my own internal feelings of I don't love myself. Okay, so that is not a very acceptable inner impulse. Okay, so it's then I project that, and it's not that I don't love myself, it's that, they don't love me, they don't want me. Okay, so and it's very commonly used with people with cluster B type personality disorders, so people with narcissistic personality disorder or borderline personality disorder. That's one of the main defense mechanisms that's being used. And so basically, anything that's internal and not accepted is projected, and therefore then is easier to be managed or dealt with. The immature defense mechanisms, again, we're moving from more pathological to gradient down to more mature. So acting out, I mean, we see that normally in people when they're like, out of character, someone who's extremely distressed, stressed, and not able to kind of verbalize their problem, they're going to act out. So you're driving and you're like, bothered, you know, other things on your mind. And then somebody cuts the line in front of you, and so acting out is like you just losing it. It's almost like a tantrum that you have. So that, the person's behavior did not require that type of a reaction from you. Okay. And again, we see it a lot in younger people because again of level of maturity. So it's the expressing of a sort of an unconscious wish or impulse through action. Okay. So that rather than dealing with or coming to terms with something. Temper tantrums are a way of acting out. Okay. Blocking is when you temporarily inhibit thinking. And this can sometimes be conscious, if someone is a bit more mature and you kind of block because you don't want to think about something. And it kind of resembles repression in a bit. Be- but again, blocking can be a bit more of a conscious thing, whereas repression, which we'll talk about in a bit, is not. Passive aggressive behavior is something that, again, we use in lay terms if someone is passive aggressive. So it's when you express aggression towards someone by being passive. So pretty much conflict avoidant. So you're really upset with someone. But instead of, coming to terms with and discussing with you ignore them. You kind of give them a short end of the stick. Um, Example is, she doesn't want to go to her husband's family, like she doesn't want to visit, but she's not going to say that she doesn't want to. So she's like, I have a backache, I have a headache, so it's really, a lot of it is conflict avoidant. Regression is when people go into like an earlier stage or phase of life. So they'll tell you somebody is regressing to like a fetal position if they're extremely sad or overwhelmed. They lie in a almost fetal position, and so that is what we call regression. But that is like physically regressed. But also we see it, for example, a 5-year-old. And there's a newborn baby in the house. And now this 5-year-old, wants to be fed by bottle because baby is being fed by bottle. This 5-year-old's language regresses. They're not talking in the full sentence, but they're like, baby talking. So there's like a developmental regression because of the stress of a baby. And so out of fear of being replaced. Okay, that's how Freud would let's say explain it. But obviously you're not gonna have a 5-year-old who say, I'm jealous of this baby, I'm gonna be replaced, I'm not gonna be, loved as much. Introjection is really interesting. And we see that with painful separation. So when close to somebody close passes away, all right, and it's a very painful experience. So introjection is almost like you introject the loved object, you internalize them. It's almost like if you have a visual of it, it's almost like you swallow them, like they're inside of you. Okay. And that way, you're able to deal with their loss versus to actually grieve and talk about it and express it. So introjection, it kind of like it's putting a band-aid on pain, but it doesn't solve the problem. So if you tend to introject, so again, conflict avoidant, dealing with pain by just internalizing it. And somatization is what we see often in conversion disorders. And so bodily symptoms that are not explained due to psychological distress. So, we see kids with functional abdominal pain, right? There's no medical reason for the abdominal pain, but, they have abdominal pain. And the source would be a psychological distress or someone who can't walk or can't see. So all these physical symptoms that cannot be explained and are secondary to psychological issues. The neurotic defenses, I mean, they more here just because anxiety in general is a very common problem, whether it's a trait or whether it's a disorder. So neurotic defenses, if you when we go through them, you may find that you have bits and pieces. Like we all have bits and pieces. So controlling is when you attempt to manage and regulate events in the environment to minimize anxiety. Okay, so it's that person who has the schedules, who makes sure that everything is in order because that way they avoid being anxious. Okay. Um, Displacement is when you shift the emotion from an idea or an object to another that kind of resembles it. So you at work, your boss kind of chews your head off. Like they give you a really hard time, or they're really upset with you. And so you're like internally really bothered and upset, but you cannot confront, like you're not going to have a fight with your boss. So what happens is you come home and you displace that anger onto, your son or daughter. So you come home and you kind of let out the steam onto that other person who has nothing to do with the problem. Okay, so that kind of displacement of emotion is how some people manage their conflict or their internal distress. Again, it's not conscious. So this person doesn't sort of take in that negative from their boss and then they say, okay, when I go home, I'm gonna like, let off the steam to, and just whoever's at home. Now, if in if in therapy, you help that person identify that this is something that they use, that this is something that they've, happens in their life, that they tend to, suck up negative energy or anger, but they don't, talk about it. They don't verbalize it. And instead it comes out on other people. Now, if somebody realizes that that's what they do, a healthier way of dealing with is to, blow off steam, go to the gym, listen to music, run it off before. So, that way, at least it's an intermediary. If they cannot be confrontational, but at least, displace that negative energy onto something that's neutral and maybe actually productive. Like if you go to the gym and you blow it off, is a lot healthier than, going home and, yelling at your kids. Okay. Externalization is to perceive in the external world elements of one's personality. Okay, so it's kind of more of a general term than projection, because projection is a lot more pathological, and it really governs a person's behavior. Whereas externalization, it's kind of like it's a way of kind of venting, if you will, like you kind of uplift parts of your personality just onto the outside world. All right. Repression is to kind of expel or remove sort of unconscious ideas of or feelings. So these, because they're so uncomfortable, they are repressed. So they don't really come forth or forward. Like you're not aware of these. And this is common in, with PTSD, people who've had been through abuse of whatever kind. And because these memories or feelings are so intense, therefore they are repressed. Okay. But they could, I mean, if a lot of feelings are repressed, it could also affect intimacy in relationships, because you're not able to, you don't feel safe. Okay. And so people can come into therapy because of issues in their interpersonal lives. Reaction formation is something that we see with obsessive compulsive disorder, very specific to OCD. And so it's when they kind of transfer or transform any unacceptable impulses into their opposite. So, my hands are dirty, so I go and wash them. Okay. My room is not tidy, I'm going to go and tidy it up. So I kind of do things to relieve me of that, impulse that I don't like or I'm uncomfortable with. Isolation is when you split or separate ideas from affect. Okay. So, so the thought and the feeling are not connected. And that is protective for some people. Again, this is not a conscious thing people do. And somebody who uses isolation is somebody that's going to have very limited, emotional type of relationships. Okay, because their thoughts and feelings are completely disconnected. Okay, so they'll come across as being very cold, reserved. Um, and so they come into therapy because they're not able to formulate relationships. Okay. And so you work with them around, how do we then, again, after identifying that as being a method or mode, you work with them on how to, better connect feelings with thoughts. Dissociation is what we see with people with split personality disorder, multiple personality disorders. And so it's really kind of to avoid this emotional distress. They go into altered states of consciousness, so they dissociate. And so it's a common defense mechanism with that type of disorder. Intellectualization is when people just overthink or to to avoid any kind of effective expression or experience, they're going to mentalize or intellectualize everything. And again, it's to avoid the feeling. And so, again, such people are very, I mean, they're doers, but not the ones that have the feeling. And so may come into sessions because of, failed relationships or failing to understand relationships. And so we come to mature defense mechanisms, which is what, would be, again, the healthiest. Okay. Humor is something that, I mean, not everybody has, but I mean, some people you'll find in very stressful situations will, joke and try to like uplift the mood, so that, people are not distressed, or they do that for themselves, they'll use humor, to, relieve stress. Altruism, is having a higher motive or higher purpose in life. So I want to be a doctor because I want to save lives. I want to, add value to life and people. So that's altruism. Anticipation, is more related to, better management of time. So I anticipate, I'm going to have a BHS exam in, whatever, 6 weeks. I need to study, I need to organize myself. And so anticipation helps planning, to avoid, further or future discomfort. And suppression, is to consciously remember we talked about blocking and how sometimes people can block things, and so, the more mature would be suppression, where you actually actively, avoid certain feelings or thoughts. For example, you have an exam tomorrow. You're distressed about, a fight you had with your close friend. So, instead of, you know, being consumed with the thought and feeling, you suppress it. You're like, okay, I'm not going to think about this. I'm consciously not going to think about this now. Let me focus on my exam, and then tomorrow when I'm done, I can deal with it. Okay, so you see that, it's just really a progression from something that's very pathological, which are the narcissistic defense mechanisms, to things that are a lot healthier, and wishing that we had more of those, or but again, someone can ask, well, can you develop, like, what if if you don't have humor as part of your, system, can you develop it? So you can develop more mature coping. So it becomes coping mechanisms. But they're not really defenses, because defenses are automatic. Okay, so things that we do without even thinking that we're doing, and we don't know their name, it doesn't have a label, it's just how we, run about our lives. So definitely, you can learn healthy coping mechanisms. You can learn that, what I'm like, the way that I'm handling my life now is not the healthiest. So what can I do to change? So there's always room to make changes. And then once you learn new coping mechanisms, and with practice, they could become more automatic, or that you can easily like kind of go to them for comfort. Okay. Um, Having completed that. So we finished ego psychology, which was primarily Freud. I'm going to move now into a second kind of school of theories about personality development, and that's object relations. So the theory of unconscious internal object relations involves the transformation of interpersonal relationships into internalized structures. So it's really all about, how does the object, how does the person deal with, whatever's around them? Okay. That relationship, that interpersonal relationship. And so the feeding process is the prototype of this of object relations, you know. It forms the basis of trust with another object being, you know, the caregiver. So templates of unpleasant experiences are transformed into positive experiences of the self. Okay. So what that means is you can have change. Things are dynamic. Remember when I said that, you know, you could have issues in the oral stage as per Freud, and then you go on to the anal stage and, you know, you have a better relationship. And so, you know, there could be that transformation. So things that are unpleasant can be transformed into positive experiences based on what's going on around us. So maybe this baby's mom was clinically depressed, has postpartum depression, so she's not able to be there as the object, but then she gets into treatment. So maybe the initial prototypical experience was unpleasant because she was absent. Okay, and then she receives treatment, and now she's a lot more interactive, and now we have more of a positive experience of the object. Okay, so again, it just goes to, you know, how amazing, you know, just having that dynamic, how life is dynamic and diverse, and how having one or a bunch of negative things happen to us does not dictate continued negativity and psychopathology. So a one-to-one correlation may not exist between the real external object and the internalized one. Okay, so I may internalize a very harsh, negative, terrible mother. Okay, but maybe that internalized mother is not, like maybe the real mother is actually a lovely, kind person, but you know, she's clinically depressed or she's got cancer and she's in treatment. So, you know, the mother of 5 children, each child will internalize this mother, the same mother, okay, will be internalized differently. Your memory or your experience of your mother as the firstborn may be very different from the experience of the same mother to your sibling who's now 5 years old, you know? So that internalized external object may not, so you know, it's not a one-to-one correlation. Okay, so it's very, very subjective. And it differs from ego psychology because the infant here transforms the mother into an internal soothing presence. Okay, they internalize the mother to soothe. All right, it's not about like sexualizing the mother. It's not the Oedipal complex where there's, you know, like a competition. No, in object relations, it's just a lot more calming. And so they talk about two internalizing mechanisms: introjection and identification. And the conflict in object relations is different from ego psychology. In ego psychology, it's a struggle between wishes and drives, you know, sexual, aggressive wishes and drives that want to come to the conscious part of our mind. So there's the conflict. Whereas in object relations, all right, so there's this, the conflict is the struggle, okay, between different, okay, so self, object, affect. So yourself with the object and how you feel. Okay, so that kind of conflict that strives for the center stage. So it wants to come to the surface is that, you know, what is my relationship with the object and how do I feel about it? So a lot of it is really affect, feeling, and not wishes or drives. So Melanie Klein was one of the people who links, you know, who talks about object relations. Okay, she talks about projection, and introjection as mechanisms. So I'm gonna just explain to you, like she looks at her theory covers the first year of life, so from 0 to 12 months. Okay, and so she says that in the first 6 months of life, infants kind of take the paranoid schizoid position. And so in the first 6 months of life, baby is hungry, baby is fed. So that is identified as a good object. Okay, so that feeding person object is good because they respond to me. Okay. But then I cry and then I'm not fed. So therefore that feeding object is bad. Okay. So the infant in the first 6 months um, feels like, they could be attacked by the bad object that doesn't want to feed them, or not, or they could be fed by the good object. So there's like that dichotomy of a good and a bad object. So it makes the infant feel like they're paranoid. They could be attacked. So now I'm hungry. I want to be fed. I wonder who's going to come. Is it going to be the bad object, or is it going to be the good object? Okay. So she says that infants in the first 6 months can get into this paranoid schizoid position, and so they want the good object and they wish the bad object to be annihilated, or to vanish or to explode, because they feel afraid of this bad object. Okay. Then in the second 6 months, from 6 to 12, the infant realizes that the good and bad object belong to the same person, okay, which is the caregiver or the mother. And so they go into depressive position because they feel so guilty that they wished the bad object to be annihilated when the bad object was really part of the mother. Okay. It's very far-fetched. It's like to understand it, that, and that was the drawback, is to assume that an infant in their first year of life could have such a sophisticated capacity to abstract think good and bad, and then feel that they're going to be attacked by the bad, wish that the bad is like, disappears, and then they realize that the good and the bad belong to the same person, and that they could have harmed that mother by wishing that she, was annihilated or destroyed. Okay. But that's how she viewed object relations. Then comes Margaret Mahler, who looks at the normal and abnormal mother-infant pairs in the first 3 years of life. And she looks at how does a child develop that sense of separateness from the mother. Okay. And she talks about three developmental stages or phases. She says that the first 2 months of life are the autistic phase. And so it's not autistic as in autism, but in the first 2 months of life, the infant feeds, cries, is not very, reactive. We don't still even have a social smile. And if you remember and recall, the visual acuity is still not in place. So everything is a haze around them. But, they're in a bubble. They want to eat and they want to sleep, and they want to be changed. Then from 8 weeks, so from 2 months to 6 months, she calls it the symbiotic phase. And symbiosis, by definition, is that give and take. So there's a back and forth. So now there's a social smile, there's a recognition of mother, there is, enjoyment in the interaction. So it's symbiotic. And it works as well for the mom who enjoys the baby. Then she talks about separation, individuation, and there's a lot of focus on that stage or phase, and it's divided into four. So the first subphase, she calls it differentiation from 6 to 10 months. Okay. Where again, when you think about, babies or infants from 6 to 10 months, they're acquiring skills. They're trying to like understand their outside environment. They start to differentiate between familiar and not familiar. So we start to have like stranger anxiety around 10 months, when they start to notice, okay, that person is strange. I don't know them. I'm scared of them. I'm going to cry. Then the second subphase, she calls it practicing, and from 10 to 16 months. And we know that at this point in time, they're walking, they're starting to talk. And so there's a lot of like that engagement and practice. The third subphase, she calls it rapprochement, and that is from 16 months to 24 months. So from about, a year plus to around 2 years. And here she kind of has a visual for us to imagine. You have a door that's sort of a bit open, and the toddler has 1 foot in and 1 foot out. Okay. So, and what it symbolizes is that struggle for autonomy. Like, I want to be with you, I want to be in the room, but I want to also run out. I want to be separate from you. I want to be a separate individual. So I have a foot out. And again, this is the time when you start to have, toilet training and the terrible twos that we, toddlers, go through acting out. And it's all to kind of reinforce that I want to be separate. I want to be an individual, but yet I don't feel I can. Then she talks about the fourth subphase, which is consolidation and object constancy. And that's around the age of 2. And again, remember magic number 2 with Piaget's sensory motor, where at age 2 we have object constancy. So the mother at this stage is, with regards to object relations, is already consolidated and she's constant. Okay. So by age 2, they formed that, mother, the object self, healthy type of relationship. And then the last slide here is Winnicott, which we know very well. And he talks about, he's one of these object relations as well, because he talks about the transitional object, which was the, blanket or your business card, but also how, positive experiences can be internalized. And you as a therapist become that good enough mother that they can then introject and they can then associate with in order to heal. Okay. The healing process comes from that better object relations. So they've had negative object relations. Their prototypical mother relationship was not healthy, and now you've become that new good enough mother, and they're then able to form better object relations because of how consistent and reliable and let's say quote unquote good enough you are. So that is the I'm going to share with you the other lecture, which is pretty short, just to complete. Okay. All right. So this is part 2. It's just 16 slides, and it just talks about one person, and that person is Erickson. Okay. And what's very different about Erickson is that he's the only one that covers the entire lifespan. Okay. If you notice from before, each sort of scientist or theory developer looks at a particular phase of life. Erickson comes along and covers the entire lifespan. He added to Freud's theory of infantile sexuality by concentrating on children's development beyond puberty. He concluded that human personality is not only determined by childhood experiences, but also by those of adulthood, which is great because then if everything goes back to childhood, then everything is somebody else's fault. And that then you cannot take responsibility for yourself. So he was saying that you have to be able to take responsibility because not everything that's happening to you cannot always be your parenting. It cannot be your childhood for everything. Obviously, some things could be, but where's your responsibility in your own development? So he formulated a theory of human development that covers the entire lifespan. It goes all the way up to old age. And he says that development occurs in a sequence, and there are very clearly defined stages, and that each stage must be satisfactorily resolved for development to proceed smoothly. Again, you can move on from one stage to the next carrying unfinished business, okay? Because you're going to continue growing. Like, we're not going to stop. Like, it's not like you're going to stop at the age of 2 for like God knows how long until you finish the business of, the oral stage. No, you're going to continue growing, and whatever's unfinished just will continue to kind of go with you. So the relationship to Freudian theories is that for each of Freud's psychosexual stages, described a corresponding zone with a specific pattern of behavior. So the oral zone, for example, is associated with feeding. Okay, the zone is associated with holding or letting go of the sphincter. The development of the ego is a matter of mutual regulation between growing children and a society's culture and tradition. So he is also a societal psychiatrist because what about the influence of society and on our development? So first stage, he has 8 stages, okay? So the first stage, he calls it basic trust versus mistrust. It's from birth to 1 year. It coincides with Freud's oral stage. And so here the objective is, feeding. So taking in nutrients, fulfilling their primary needs. And so a trust-inducing mother is going to attend to those needs. And so she lays the groundwork for the future positive expectations of the world, okay? That's pretty much what Freud was saying is, it's this positive future expectation of the world based on the infant's experience of being, having their needs met. Okay. The parent attends to the infant's senses, and through this interaction, they develop a feeling of trust that their wants will be satisfied. And if the mother's inattentive, they may develop then a sense of mistrust of the world. Again, it depends on her level of inattention. So if she misses, again, we're human. Moms, we cannot expect that moms to be robots and to be there because we said that, if the parent is overly attentive, then you're going to develop a very entitled and very demanding human being. And we don't want that. So we're talking about the inattentiveness that will then lead to having an insecure or an ambivalent type of a relationship because they can't trust her. So the oral crisis, he talks about in the second half of the year, okay, so 6 months to 12 months, where the infants start to develop teeth. And so they're more active in their feeding. And so if they bite, obviously moms are going to pull away. So here they learn that they can influence the environment. Okay. And that's the beginning of feeling that they're separate. So I can influence the environment around me. Okay. Now, obviously, the mother's reaction to that. So if the infant bites and the mother yells or screams or, is very different from mothers who pull away and then they try to soothe the baby. So again, it's dynamic. So the outcome, the number of variables is infinite. Weaning is a separation, and if basic trust is strong, the child develops a sense of hope and confidence. I remember I saw a 4-year-old who's still breastfeeding. Okay, the mom was still breastfeeding, and I'm like, why? Why are you still breastfeeding a young human being? So she had issues here with separating. The mom was again her own issues as well of feeling being abandoned herself. So very complex case, but the simple presentation was I'm not able to wean my 4-year-old from breastfeeding. So the development of trust, the first social achievement is letting the mother out of sight without anxiety. Okay, and that will happen, closer to age 2. Okay, this will happen as she's an inner certainty in their mental representation. So not only do they need to internalize her, but they need to also understand that, when she's not there, she hasn't disappeared. Okay, so here, your understanding of the cognitive development, social development, object relations, all of that, comes into play to understand, how it is that infants feel like they can trust if the mom's not around. Stage 2 is autonomy versus shame and doubt. So from age 1 to 3 coincides with Freud's anal stage. Autonomy is associated with a sense of mastery. Toddlers have a sense of being separate from others. I, you, me, mine. They have a choice of holding on or letting go. In the toilet training process, being cooperative or stubborn. Parents allow their children to function with autonomy and are supportive. They're not overprotective. And so that allows self-confidence. If toddlers are punished for being autonomous, this produces a sense of shame and doubt. So, part of normally developing is to become autonomous. So if my parents don't allow me to become autonomous, or if they punish me, Then I'm going to grow up always feeling like I'm doubting myself, doubting my decisions, feeling embarrassed about what I think or how I feel, you know? So these are like the two ends of the spectrum. Stage three is initiative versus guilt, age 3 to 5. So the infamous phallic Oedipal phase. So here you have this child's growing sense of sexual curiosity, because, like we said before, in the way they play or they touch or look at themselves. And so if parents don't make a big issue, okay, these impulses eventually are repressed and they reappear in adolescence because of the hormonal, development. So getting close to age 3, if the initiative is reinforced, it will create ambitious kids. Now, it doesn't mean that you just allow your children to touch themselves and, be all over the place. No, that's not what is meant by initiative. But the idea that they're curious. So kids in that age are so curious. So you want to foster that curiosity. And so then you're going to create ambitious kids. But if you have a curious kid, like who's asking you, why is this, why is that? And you're like, I don't know, or you don't have the interest to, tell them, oh, let's sit and let's try to figure it out, or let me show you this, then you're not going to have a very curious child. You're not going to have a very ambitious child. At the end of the stage, the super ego is established. And so you have a moral sense of right and wrong. Proper resolution produces responsible, dependable children versus, parents who parent their kids to foster guilt, you make them feel guilty that they breathed the air that morning, so they have a very harsh superego. So at one end you have children that are ambitious and curious, and on the other end you have somebody who, is always like guilt laden, like they walk around just carrying the sense of guilt just for having a thought or having a feeling. Stage 4 is industry versus being inferior. So it's age 6 to 11, and that's Freud's latency phase. Here, like we said, they're involved in organized learning. And so key here is industry. So industry is the ability to work, to acquire skills. They learn that they're able to make things and master tasks, to do things well. Being inferior occurs if they're always discriminated against, if they're protected overly, they become excessively dependent. So they're, going to grow up feeling inferior versus having the sense of industry and accomplishment. Stage 5 is identity versus role diffusion, 11 through end of adolescence. So the developing a sense of identity here is the main task, and that coincides with puberty. And identity are the characteristics that describe you or as the person that you are. And you can have an identity crisis here. So at the end of adolescence, it's kind of normal for teenagers to kind of go through that. But if you have a very solid, supportive, a parenting environment, you go through that smoothly, like that questioning of why, where, what, how, that kind of a dilemma, very existential, can be managed. So failure to resolve leads to role confusion, problems with gender identity. Here, teens, they will defend against that confusion or diffusion by joining cults. If I can't figure out who I am, then maybe I could be identified as a member of this cult or this gang or whatever, because I want to feel like I have an identity because I feel so confused. Stage 6 is intimacy versus absorption or isolation from age 21 to 40. So late adolescence to early middle age, intimacy in relationships is not frightening for people who don't have identity issues. If they've resolved the crises, they know who they are. So now they're able to, go on to becoming intimate in relationships. Without friends, people become self-involved and isolated. So people should establish very kind of mutual, extended, diverse social groups. I mean, we always advise, have plenty of friends, but also have some very close friends. Don't put all your eggs in one basket. Don't just say I'm just gonna, all I need is this one person or two people in my life. People change. So the more diverse your social circle is, the less likely you're going to become isolated. Stage 7 is generativity versus stagnation. So from age 45 to 65. So here it's just not being not only concerned about your family, but also establishing, guiding oncoming generation, improving society. So things like, what's it called? Volunteering, establishing support groups. Parents need to have achieved successful identities, and then adults with no interest become self-involved and stagnant. And then they become unable to accept the idea of death, which is, an ultimate end to everything. And then stage 8, which is integrity versus despair and isolation. So over 65. So here you have a conflict between integrity, which is your satisfaction with yourself over your lifetime. And, 65, you look backwards because, again, the looking forward, I'm not being very pessimistic, but I mean, obviously, if you're 65, a lot more has finished versus what's left. So you want to be able to look back and say, and look at your achievements, whether, at least again, the achievements are based on your goals. For some people, it's family. For some people, it's money, it's business, it's whatever it is that you've set out for yourself. Have you achieved those goals or not? So that will make you feel like you're satisfied versus despair. Integrity allows people to accept their past and their accomplishments. And again, growing old needs active preparation. Like, it's not just a passive ride. You're not just, uh, you know, on a ride and not you don't know where you're going or how it's going to end. You need to be active in the sense that you work on your future, you work on your health, you work on your relationships, and you invest in all of that to, ensure a better outcome later on. And again, كل بإرادة الله, like, you do as much as you can, and the rest is up to Allah. So healthy children will not fear life if their parents have integrity enough not to fear death. Again, we are like the mirrors to our children, and how we deal with life, health, wellness, illness is something that our kids will go on to acquire and see. So that's the end of our second lecture for today. Inshallah, next week I'll see you on campus next Thursday, inshallah. And if you have any questions from what we've been talking about today, please let's discuss it next week when I see you. All right?